Welcome, everybody, to Champions in Higher Education for XR. Champions for Higher Education XR, or CHEX, is part of the Immersive Learning Research Network. I'm one of the co-chairs, Rob Terrio. I'm the Immersive Technology Manager at Georgian College in Ontario, Canada. And with me is co-chair Dr. Stephanie Justice. You want to say hello, Stephanie?
Sure. Hi, everyone. I'm an assistant clinical professor at The Ohio State University and the College of Nursing, and happy to have everybody on today.
And also with us is Dr. Jonathan Richter, who is the president and CEO of the Immersive Learning Research Network. And I'll let you say hello, Jonathan.
Hey, everybody. Welcome, and thank you for joining us, especially to our special guest. This is fantastic, and can't wait for this awesome webinar.
Excellent. So thanks, everyone, for joining us. Really excited today. We have a couple of really great speakers I'm excited about, Dr. Anne Lord-Bailey and Caitlin Rollins, and I'll just give you a brief bio for the two of them. I had the good fortune of meeting Dr. Bailey at a metaverse event in Washington, D.C. recently, and we had a good conversation. I was just in awe at the scale at which the VA is exploring and integrating virtual, mixed, and augmented reality into a variety of different areas. So Dr. Anne Lord-Bailey is the Executive Director of Strategic Initiatives Lab, this also known as the Strat Lab, and Immersive Technology Lead for VHA's Office of Healthcare Innovation and Learning, otherwise known as HIL. Dr. Bailey started her healthcare career as a pharmacy practitioner, and in 2021, she became HIL's lead for immersive technology and became the first executive director of the newly formed Strat Lab in 2023. She's worked with experts and thought leaders in government, academia, and industry while co-leading the expansion of VHA's extended reality network from the founding 5 facilities to over 70 now, engaging more than 2,300 VA employees and helping guide the implementation of immersive technology use at scale for more than 40 indications. In 2022, Dr. Bailey was awarded International Virtual Reality and Healthcare Association's Hero Award for dedication to the growth of immersive technology in healthcare. G2 Exchange Change Agent Award and the Service to the Citizen Award. In 2023, she was named a top 12 finalist for the Service to America Medal People's Choice and Washington Pinnacle's Executive of the Year. Caitlin Rollins has also joined us. She is the Deputy Director of Clinical Tech Innovation for OHIL, VA Immersive. She's been in the nursing profession since 2011 and with the Department of Veteran Affairs since 2017. In her first year of VA practice, she initiated the first positive distraction-focused virtual reality program for pain and anxiety management in the Veterans Health Administration. She now aids in leading VHA innovation and immersive technology utilization as Deputy Director of Clinical Tech Innovation, co-lead of the VHA Extended Reality Network, and Program Manager for VA Immersive in the Office of Healthcare Innovation and Learning. She has directly supported the expansion of HR technology use from one facility to over 90% of VA healthcare systems and XR network engagement to more than 2,300 VA employees, including development pilots, programs, and healthcare. So thank you both for joining us. Really excited to hear what you're going to tell us and our audience about today. Thank you.
Thank you so much, Rob, for having us. Apologies for those long intros. Wow, what people mostly want to know, at least about me, is that, yes, this is my natural hair color and Lord is my middle name. So that's really, we probably covered everything people are interested in. So you can go to the next slide, Caitlin. One of the things we always like to emphasize is that this is a team sport. You've heard plenty about Caitlin and me for sure. Evan Davis is another one of our teammates, recreation therapist by training and joins us as a project manager. And then Jared Riceweber, who's done a lot of work in mental health and now on a detail with us for implementation. Excited to have the team working together. Next slide. We always like to emphasize so that we can speak freely. We don't endorse any particular company or product, and also the way that we are leveraging this technology, particularly in mental health care, is as a support to our providers. We don't use this as standalone treatment. We want to leverage it to empower our staff members and support our patients, whatever that might look like. Next slide. For those of you who aren't familiar with Veterans Health Administration, we are the largest integrated safety net healthcare system in the country, in the United States. We serve more than 9 million veterans. We have 172 medical centers and almost 1,200 additional sites of care. We're the largest provider of graduate medical education. We train about 70% of healthcare professionals in the United States, at some point rotate through the VA, myself included. We are a major contributor to medical and scientific research. You'll see that on the next slide and some of the innovations that have happened, but more than 400,000 staff and 25,000 volunteers. Next slide. So very complex organization, certainly positioned well to scale when things are successful. I mentioned major contributor to research and also to innovation, and these are a few examples. The first clinically successful implantable cardiac pacemaker, liver transplants, our first robust scaled use of an electronic health record in the 90s, I believe is when that happened. Powered ankle foot prosthetic, the first FDA designation to the VA for compassionate use authorization for a 3D printed hearing device. It's called a GeoStent if you want to look up and learn more about that, but a veteran in South Carolina actually had the opportunity to name it, and he named it after his grandson, so that's why they call it the GeoStent. And then what you'll hear more about today, leader of clinical implementation of immersive technology, with virtual reality certainly being the largest of that example. Okay. We want to make sure we level set on terminology, that we're all talking about the same things when we talk about things. So immersive technology certainly being the most inclusive term, which is why we use that, but doesn't always necessarily mean something is on your head. Immersive technology can include things that are certainly external, but basically helping you feel like or think or believe that you're somewhere different than you physically are. As we narrow that to including a head-mounted display or something on your head, that we start to call that extended reality or XR. And even within that, there's a realm of different types of devices and capabilities. Augmented reality being the least immersive. So often with AR devices, you'll see one on a slide coming up. You can see people's eyes. They can see the physical world around them. There's just a digital overlay. No opportunity for that complete immersive experience. And then progressing forward all the way to the most immersive being virtual reality. Historically, even over the last year, it was probably 6 months ago that we started adding mixed reality and spatial computing, as you can imagine, based on the new devices that have come out. But prior to that, there wasn't really a clear definitive example or definition of those two as it relates to head-mounted display. So we've added those, but won't talk about them significantly today. Next slide. So these are examples of augmented reality versus virtual reality. On the right side, you can see that this person is on their back porch, probably in Western North Carolina, where Caitlin and I both have the privilege to live. A beautiful environment for sure, but they're interacting with that digital overlay. It's the same exact experience on the left side of your slide, but you can see that they're completely immersed in that virtual environment. So what we would say on the right side would be augmented reality, on the left being virtual reality. Okay. It's always complicated when we add videos, but those are really important. So you can keep going. So I'll tell you a little bit of the story about how this all got started in the VA in 2017. Caitlin and I met. At that time, we have now uncovered that there were about 7 different medical centers that were using virtual reality for several different indications, mostly around post-traumatic stress, pain, some staff education and training. Importantly, none of these medical centers knew that the others were working on this. And so when Caitlin had her opportunity, she was looking for a way to solve the challenge of postoperative knee pain and anxiety, and VR was recommended. I think she reached out and couldn't find anybody else that said that they were doing this, thought it was a good idea. But what we saw happen with Caitlin's original project was impact on pain and anxiety for sure, decreased medication use, decreased length of stay, things like that, but also incredible engagement and an opportunity to really lean into what does it look like to scale this type of technology. And so we developed the extended reality network or the XR network and started to share resources, processes, things like that. So next slide. Now what we have across VA is headsets in all 50 states, as well as in several American territories, Guam, American Samoa, Puerto Rico, really speaking to the portability of the technology, which is incredibly important, particularly in this day and age. And additionally, we've documented more than 40 indications of use across these medical centers and sites of care. Okay. These are a few examples of those active use cases. Certainly, this is not an all-inclusive list, but it gives you an idea, whether it be in clinical areas, substance use disorder, addiction recovery, phantom limb pain, things like that, or in how we engage with our staff, new employee orientation, and some staff-patient collaboration interaction, pre-surgical planning, things like that. Also continuing to expand into areas, of course, training and education, but patient education specifically. We also like to note that the pictures you see throughout this deck are not stock photos. We have the privilege now to be able to actually share pictures of our actual patients and staff using this technology in real world clinical practice. Okay, next slide. We also want to talk about why. I mentioned that you'd see an AR device. There's one there. If she were to look up, you'd be able to see her eyes. But one of the things that's important is the growth of immersive technology in healthcare. We've certainly seen this progression, even in people's understanding of the opportunity of leveraging immersive technology in healthcare. But in 2020 being 2.7 billion to projected 41 billion in 2026. Importantly for us, all of our patients come to us from the Department of Defense, from the Army. We serve veterans. And the Department of Defense is investing significantly in immersive technology, which means by the time veterans come to us, they've already had some experience with the technology. And the Army is using this, one example, a $22 billion program to equip the lowest level infantrymen with skills of fighter pilots, an example of learning, training, and education. And then we know there's increasing evidence to support that learners are learning faster, they're more confident in their skills, they can certainly practice asynchronously, they're emotionally connected, and are more focused than even those who are on a 2D screen. Okay. We also get a lot of questions. Where's the evidence to support? And so one of the things that we've done over the last year or so is pull together a literature review. This is not all inclusive. There's certainly things that are missing and more that we could add, but we wanted to have a resource we could hand to our staff, but also make this more publicly available. On the left, you see the different indications that we have gathered some of the literature around. And then on the right, a summary of what we found. So a summary of benefits are things that certainly we're appreciating, some cost savings, increased access to care, the ability to collect data for sure. Importantly, on the barriers piece, this is really where we've focused and even heard from our staff. It's important to focus access to the technology. How do we make it more accessible? So if we're seeing all these benefits, how do we help everybody have the opportunity, keeping of course, diversity and inclusion in mind in that dissemination? And then historically, there's been limited training and education. People have just tried to have to sort of figure out how to use the devices. And we have created some courses internally and also are building capability to do some in-person demonstration and training as well. And then ease of design. We find human-centered design to be really critical in the process of using this technology, and certainly want to contribute to continuing to improve the design. With that, I'm going to hand it over to Caitlin.
Thanks, Anne. And kind of continuing with that justification for why immersive technology, this is just an example of some of the early patient outcomes that we saw at the Western North Carolina VA, where Anne and I previously worked. And this, you see the images there of the very first patient that I ever used immersive technology with. And so these early patient outcomes started to provide, of course, the justification for us and started to grow our passion for this technology because we saw what positive outcomes patients were having. And then as that original program continued to grow, and you can see it grew from one inpatient unit to a lot of different patient areas for other use cases as well. So you see that on the right on the slide, as well as some of the sustained outcomes that we continue to see from one of those earlier pilots that, like I said, contributed to our justification for why immersive technology should be a part of veteran healthcare. From that earlier work, we also did some qualitative analysis of candid remarks from patients related to their experience. And feel free to check out this article that was published. But I wanted to call out one particular section of it where those themes that were determined based on that qualitative analysis, one of those was that virtual reality opened veterans' minds to other non-pharmacological modalities, so kind of lowering that barrier to entry, which becomes important too as we start thinking about how we educate our clinicians in the ways that they might use immersive technology to benefit patient outcomes. So it's not always just clinical education and training and learning skills in that manner, but also learning how to use the technology itself, as Anne just mentioned. And Anne and I had the opportunity to speak with the Wall Street Journal last year as well. And so wanted to just show how immersive technology is and may be used for mental health as well. And Anne provided the revelation during that interview that it's much easier to multiply headsets than mental health providers, meaning the technology provides a means of augmenting the limited number of mental health providers as a supportive supplement to face-to-face care. And I think we could think of a similar example, of course, with education as well. So it may be easier to multiply headsets than educators in certain situations. So just something to ponder. And as always, we like to highlight the voice of the veteran. So I mentioned those candid remarks that we collected at the Western North Carolina VA healthcare system and did some thematic analysis on. Here's some examples of those. And we get similar comments in a kind of different category from the clinicians, of course, that we trial different education and training content with. So not only is immersive technology, of course, beneficial in supporting the care of veterans and other patients through those patient-facing use cases, but we also know that immersive technology is an incredibly powerful tool for training and education, both clinical and non-clinical. So we'll talk some more about some of these potential uses for immersive technology in education and training as we continue through this presentation, but you can see some on this slide that the VA is already diving into. So, as I mentioned, XR has that potential to impact training and education in many ways. And we've already seen that in some of our pilots and implementations in the VA. And as I mentioned, this can be a clinician-led intervention for patient-facing use cases, but those clinicians also need to be trained on how to appropriately and safely use this technology in those different scenarios, making that education and awareness a part of new clinician training or continuing education can really go a long way in sustaining its use in clinical practice. And as Anne mentioned, we have been developing content for clinician and other employee education, what we call XR 101, and we're developing an XR 201 to provide that training to allow clinicians to really take advantage of that as a clinician-led intervention. And then, of course, XR may be used with clinicians and other employees or even caregivers to build empathy. So training them through the use of an immersive technology platform to better understand the experience of others, which can, of course, improve customer service, improve teams, improve the quality of patient experience or encounters. And then lastly, and of course not least, it can, of course, be used for clinical education and training. So those clinical skills across an entire range of disciplines, surgical planning, et cetera, as well as patient education on diagnoses, conditions, proper self-care, as well as co-planning for procedures or surgeries. So just to do a bit of a deeper dive into the benefits of immersive technology for clinical education and training, this is pulled from that literature review that Anne mentioned a moment ago. So looking specifically at those benefits that we pulled from existing literature. So for clinical education, looking at the application of learning, observation and peer interaction, social skills, of course, that experience and empathy piece that I just mentioned, as well as, of course, increasing confidence and self-efficacy. And then with training, of course, improving the clinical experience, improving clinical outcomes, safety. So having that safe space to continue to practice, and also having a means of basically scoring yourself as well, of course. And then standardization of training too, increase access to training. There's a lot of potential benefits of this that we have been able to pull out through the literature and that lit review for VA Immersive. So this slide just provides a sample of some of the current pilots or programs within the VA for education and training currently. Of course, we work with industry and academia, both through procurements and cooperative research and development agreements to determine needed pathways, needed resources, processes, customization of content, and to, of course, collect feedback from both our clinicians and other end users to continuously iterate and to improve on those solutions to best meet the needs of healthcare. So Anne mentioned, we very much believe in human-centered design. And so we really take the opportunity to work with those that are in this industry, work with those that are also working in this space so that we make sure that the solutions that we do bring to the front line and to healthcare are what we actually need. I just wanted to highlight this. Feel free to take a look at these manuscripts. These are just examples of virtual reality for clinical training and education literature from VA employees. There are others, but we wanted to pull out these so that you could take a look. One is about using virtual reality for practicing and learning more about assisted falls. And the other one is using augmented reality at one particular VA medical center for training purposes. So now I'm going to kind of do a little bit of a deeper dive into some of our existing VA immersive projects and pilots. One of which is this virtual reality for the prevention of sexual harassment training. And this is meant to supplement existing sexual harassment prevention training, really enabling the user to step into the shoes of a female veteran at a VA medical center to build empathy. So going back to that empathy training that we were talking about, and to develop skills to act when sexual harassment is seen or experienced. And this is being done in collaboration with our Assault and Prevention Office. So we have a number of facilities that have already been participating in this. And as we mentioned, it's important to get feedback. So a lot of the build of this and all of the iterations are based on real clinician feedback. So the different builds of this particular platform are taken directly to those medical centers, and you can see folks in these pictures actually trying that content and providing their feedback. And then the company we're working with to help build it, they make those changes to the content based on that. So it's incredibly important to get that end user feedback to make sure that we are capturing the needs. And then also based on an empathy training experience, we worked with the Veterans Experience Office to develop a virtual reality-based scenario to allow employees to experience firsthand what veterans experience during that process of discharging from the hospital, which all of you in healthcare probably know it can be a very stressful situation. They might get confused, overwhelmed. There's a lot going on. So this, what we call Moments That Matter, is really just meant to build empathy. It's all based on insights from actual veteran patients. So going back to that human-centered design aspect again, and it's really just designed to inform and empower staff and ultimately improve the patient experience at VA medical centers. So it's really allowing you to kind of have a day in the life moment of an actual patient going through that process. And we have a number of facilities, I think 10 at least, that are currently participating in that pilot as well. And then just a little bit of data from that particular pilot. So there have been a total of 10 facilitators, 18 site champions, and we've had 318 participants complete more than 145 sessions. And 93% said that they experienced empathy for the veteran, which is important, right? That was the goal of the training. 90% saying that the training positively impacted how they will interact with veterans in the future. So that customer service piece I was talking about, better understanding the experience of others so that we can improve our interactions in the future. And then 90% saying they would recommend that training to their colleagues. Another training that we have developed, and this one in collaboration with the Veterans Crisis Line and our Office of Mental Health and Suicide Prevention, is really meant to increase VA healthcare providers' familiarity with firearms, enabling them to better support veterans in crisis. So this virtual but very experiential introduction to firearms ammunition, and methods to actually safely secure and store firearms and ammunition helps those that are maybe not as familiar with weapons or with guns to actually learn in a very safe space, relevant terminology, all those proper safety techniques, and ultimately, like I said, with the goal of improving providers' confidence and comfort when talking with veterans. So like we've heard from individuals, well, I always have these gun locks in my drawer to give to veterans when they're in need, but I don't even know how to place a gun lock myself. Well, this sort of training allows clinicians and other providers to actually learn how to do so in a safe space and in a very real way. Got a little too happy with the clicker there. So just some opportunities that we're recognizing within the VA and outside of the VA. There's always the potential for those novel use cases. And, you know, as Anne mentioned, all of this that has grown within the VA has really grown from the ground up. So really the clinicians, the VA employees really pushing this forward as they think of problems that they've encountered, whether that's in clinical practice or educational needs, and they bring those to us, say, could immersive technology help with this particular problem? And that's an important piece of what we do, is determining if, based on the problem, immersive technology is the right solution. It's not always the case. We know it's not the end-all be-all solution, but for some of those novel use cases, immersive technology could be a game changer. And then looking at how we can use the technology for peer support. So supporting their mental health, supporting their social experience. So looking at how we can use group sessions in virtual worlds outside of VA medical centers. So this is talking about use outside of our four walls to better support our patients. Of course, looking at how we can equip and augment clinicians. And as I mentioned earlier, how we can also augment educators. So how does this technology allow us to spread the reach of our healthcare systems and our education system in a very real way across state lines, across country lines in some cases? And then looking at remote asynchronous or synchronous care, and this is more of the patient-facing bit of it, but how do we use immersive technology to support at-home self-care, building life skills, pain management, rehabilitation, and access to other complementary modalities? And this could also, of course, include access to patient education. So I was speaking with a site recently who is very interested in developing XR-based education, patient education for congestive heart failure based on a curriculum they had already developed. But they feel they'd get better engagement if it was in a virtual reality headset, and even something the patient could take home to continue to do exercises, gamified educational experiences, to continue to teach them the things that they need to know to hopefully prevent future hospitalizations in the future. And Anne, I'm turning it back to you.
Oh, you're muted, Anne.
I was on a roll. Like I think I was at 10 days without doing that. So my apologies. Thanks for calling me out. One of the things that we like to talk about is where are we going next, right? So these things are changing so quickly. And I mentioned this briefly as we talked about what we learned from the literature review. But one is increased access to headsets within our system. We want to make them, as Caitlin brought up so many wonderful examples, make them more accessible both to our staff and to our patients, both at the medical centers and in their homes. Then we want to make sure, as a part of that making more accessible, is that we're standardizing training and education. This for us goes beyond just teaching people how to charge them, clean them, turn them on, those kinds of things, but actually where do they best fit? Where can we use them better? Where can we use them differently? Because one of the things we know from having people put their heads in headsets, which is really our mantra, is that people take those headsets off and come up with brilliant ideas of how else we might be able to use those. And we really want to continue to work together in that space. And then finally, access to more and better data. One of the things that we have the opportunity, given our size and scale, is the ability to pull together a lot of information and a lot of lessons learned, as well as how can we better implement and apply this? What's the most appropriate, whether it be patient population, staff education, use case, how do we think about those kinds of things? And certainly over the next several years, But immediately we want to be thinking about those kinds of things. Okay, next slide. The other thing that's really important to us is thinking about how do we make this easier for our staff, and then how do we communicate that more broadly. So some of the resources that we have available within our system, and certainly these are opportunities to learn from some of the things that we've learned around the community building piece. We have an XR network that we've mentioned a few times where we have more than 2,300 members, almost 2,400. I think we're too shy as of this morning. But in this cloud-based collaboration space, we share standard operating procedures, templates, guides, those kinds of things to make it as easy as possible to continue to implement and apply these things. We also have communities of practice where at most monthly, at least quarterly, groups get together to talk about this type of work. That started with an Immersive Tech general community of practice. This one's VA only, so we can speak freely and highlight what our staff are doing internally before we make it more publicly available. But from that particular group of people that meets monthly, we had several reach out to us and say, hey, can we talk more specifically about employee well-being? And so that group now meets monthly as well. And then same types of questions around mental health rehabilitation and pain management. Those either meet bi-monthly or quarterly. And then we've talked about it a few times, but it really is critical, that continuing education, common language. And so we initially were teaching an XR 101 course quarterly and virtually. We found that making that available on demand is actually much more helpful to our staff, particularly given this pace with which this is continuing to pick up. And we also know credits, continuing education credits or units are really critical. So we make that available with CEUs for more than 20 different clinical disciplines. As that, we've learned that there are places where we need to go deeper. And so we've started developing a 201 course that we hope to have available in the next month or two. Okay, next slide. And then we have cataloged so much of the lessons that we've learned into several different resources that are publicly available. You can go to our webpage, innovation.va.gov. There's a VA Immersive section there. We'll drop a QR code or pull up a QR code in a bit that you can link to those. But on that webpage, you can find our implementation guide. These are the processes that we've learned within VA. So it may not match one-to-one, but it gives you a general idea of how do you think about building a program around this technology. And then the intro guide gives a lot of information about definitions. So we started with definitions. We want that to be common language. We have definitions there for sure, but we also have examples of the platforms that are being used in at least one VA somewhere, how those are being used, what's a general description of the experiences or the technology, and then where in the medical center, so that you get an idea of how you might implement it if you wanted to adopt any of those types of things. And then we prioritize demonstration, heads and headsets. So getting people to experience the technology is certainly critical. And one of the ways we do that is through these veteran experience events, or VXR. We also now have those available for our employees, or EXR events. And we know that event planning can be a hill too far. Certainly it was a learning curve for us. And so we cataloged a lot of those things in our event planning guide as well. Next slide. These are some of the links and resources that we mentioned. So innovation.va.gov, there's a place there for VA Immersive, but certainly you can learn what our office, the Office of Healthcare Innovation and Learning, is doing more broadly. The Diffusion Marketplace is actually a place where they share best practices. It's a publicly available site, best practices of things that are happening within VA, where are those being adopted and how you could adopt those, whether you're in VA or not. They've also graciously given us a little section there for VA Immersive. This is not all inclusive. It's dependent on our staff actually wanting to put their practices on the Diffusion Marketplace and then being able to maintain it, but certainly gives you an idea of some of the things that are happening. And then the final place is maybe one of our most exciting that from our perspective is our playlist on YouTube. So you can hear from veterans themselves and some of our staff members talk about why immersive technology matters to them. You can also, we do an immersive summit every year, and the second year, actually all those talks are cataloged there on that playlist. So it's a really cool resource, we think. So we'd love for you to go there and view some of those as well. Next slide. And if you have any questions, vaimmersive@va.gov. Caitlin and I certainly want to be as much of a resource as we can. We've found that there is no reason for anyone to start where we started 7 years ago. So if we can help you move this forward, answer questions, make things easier and that kind of thing, we are more than happy to do that. So with that, we'll hand it back to you, Rob, and happy to field questions in real time if that's helpful.
I'm on cerebral overload now because there was so much information there, and even when you and I met briefly, my brain was exploding at the notion of how you've taken this and Caitlin have taken this to scale with so many headsets and so many activities, 40 indications. It just blows my mind. So, you know, in my own head, I tend to divide things into VR for therapy and VR for learning, and my focus is VR for learning, and I completely ignore the mental health part, the therapy part, because it's so massive. It's so much research going on in so many areas now, but it just blows my mind, the incredible things that you're doing. So thank you so much for sharing that information. And I have a billion questions, but we have some questions from our participants, so I'm gonna read those off. So the first question is, how might the panel recommend developing VR protocols for secondary trauma?
Caitlin, I don't know. I can start that, Caitlin, if you want to add to it as well. One of the things for us has been really critical. I'm a pharmacy practitioner by training. I specialized in hepatitis C for a while, and then primary care, and now in anticoagulation and cardiology. And Caitlin has a clinical history as well. What's really been critical for us is that XR network of 2,300 frontline staff who are really uniquely gifted in the areas that they are clinically. So that's where we lean in. Any pilot that we have, any of those that you saw listed, Caitlin has worked very directly with those staff members to develop metrics, guidelines, protocols, that kind of thing. But Caitlin, I'll let you add to that as well.
If I can get myself off of mute anyway.
At least you knew to try.
My VPN decided to cut out right in the middle of all of that. So, you know, connecting to government computers from your home, it means that I lost all audio. So, Anne, I need you to give me an idea of what the question was.
Basically, how do we help outline protocols? The specific example was secondary trauma, and was just saying that so much of it is dependent on our clinical subject matter experts.
Oh yeah, no, it definitely is. And I actually had this conversation with a clinician yesterday when it came to protocols for different use cases or different clinical indications. So much of it too needs to be very much dependent on the end user, or in this case, the patient. You know, if you try to come up with a protocol for pain management, for example, and you say the patient needs to use virtual reality 15 minutes a day, 5 days a week, great, but maybe that's not appropriate for every patient, and it may not get you the same outcomes between individual patients. So I always tell clinicians, you really need to really customize the experience to the patient in front of you, that individual patient, because the way that they interact with the technology, what might be beneficial to them, is going to change depending on who you're talking to. Like, I may benefit from relaxation content and mindfulness to help with my pain. And then there may be another person sitting beside me that needs interactive games to be able to distract them from the acute pain they might be feeling post-operatively. And the relaxation content does nothing for them. So if you try to set up a protocol without that customization or autonomous selection of environment, then you may not get the same outcomes.
Someone asked also if there was a link to your lit search. So if there is and you're able to put it in the chat, that would be great. The next question is, do all of your patients agree to use the VR headsets, or do you have patients that are reluctant to do so? And in which case, what kind of options do you offer for those who don't tolerate a VR headset or no interest in VR?
I'd say it's pretty rare that we have people that are just completely against immersive technology. You know, most of our veteran population, although it's increasingly becoming a younger population, the majority of our patient population has been, you know, what I would consider to be older adults. And so there's a lot of inaccurate assumptions about who may or may not want to try this type of technology. Of course, our younger patients are very they played video games growing up. They've probably already tried a virtual reality headset before, so they have less barriers for that. But even our older adult patients have been incredibly open-minded to this, and sometimes even more excited than the younger population because they've not really been exposed to it in their lifetime. And so I think it very much depends on how you talk to patients about it too. You know, what is this? What are they going to experience? How might it help them? How might them using it help others as well in the future? Our veteran patients really love to help each other. So if we tell them, hey, try this out, you know, your opinion about this may help other veterans in the future, it changes whether or not they might want to try it. Some patients are not going to be appropriate, and we do provide a standardized clinical guidance document with contraindications and precautions, and that can be used both for patient-facing and employee-facing use cases. So anybody that's going to implement the technology, they have an understanding of the situations in which this is not an appropriate intervention for this patient. And in those situations, you know, we offer a lot of different things in the VA, so there's usually another solution that may be beneficial to that patient. So it's not like they're going to completely miss out on an aspect of their care, but you're right, it's not always appropriate either.
Right. Another question here, is integration with tools you use to track learning and development, example of learning management system, important for your partners? Do you have standards around that type of integration?
Yeah, I can help with this one. This is one of the things that we're really working on. One of the key aspects to this growing to the point that it has, and hopefully it's grown enough that people won't have to start exactly where we did, but was that things being in kiosk mode or single app mode was really critical. So the devices were very siloed. So because they were not on any system, there was no integration, interoperability, standardization was less important, though I would argue, and Caitlin, I believe, would as well, that the user experience being standard is always helpful. And that doesn't yet exist. And so those standards and requirements are what we're actively building now, both from the design development perspective, the hardware, the content standardization process, informed in no small part by our privacy officers, information security officers, information technology teams. Again, getting back to VA is a large, complex organization. But also the other part of that being, again, the user experience. So similar to how we think about driving cars, I've heard this example, Dr. Walter Greenleaf gives this example often, and I think it's very helpful. If I go rent a car, I may have to learn one or two things about where, you know, how to turn on the windshield wipers or the blinker, but generally I can pretty quickly figure out how to navigate that car rental. We need for immersive technology experiences and technology to be the same way. We need it to be very seamless, very intuitive, but also consistent. And those are certainly standards that we're in the process of designing and developing now in collaboration with industry and academia as well.
Right. Okay. And you and I talked before, and you know that I'm very passionate about the concept of open source XR. And so I'm not sure how to frame this, but if you've got experiences, and I hope you will think about partnering perhaps with some universities and colleges around sharing some of those on a perhaps an experimental basis. You know, I think of things like training for sexual harassment and other empathy tools that would be very valuable to schools and students in healthcare disciplines. So I'm just, that's more of a statement than a question, but I hope that's something that the VHA will consider.
I think hopefully we try to emphasize collaboration and community building, not just within VA, but more broadly, has been really critical. Jonathan, thank you for sharing those standards as well. We'll take a look at those.
All right, thank you. Just wondering if there are any more questions from either Stephanie or Jonathan or anyone else in the audience.
I don't have any questions, but I wish I would have seen all of this before we launched our lab a couple years ago. You could have saved us a whole lot of headaches because I've already got like all of the websites up that you talked about. and I've been trying to listen and look at some of the resources, and there's quite a bit on there. So very impressive, and I think it's amazing. I'm like, oh my gosh, I need to read it all.
Yeah, I was thinking, Anne and Caitlin, you guys should hold like a 1 or 2 day event where kind of an EXR event for external people like us who are, exploring XR, just so we can learn from your experiences and perhaps do some knowledge sharing between various organizations. That would be super cool. Yeah, we should get you at one of the Immersive Learning Research Network conferences. Hey, Jonathan.
That's right. Would love to collaborate with you both and the department. This is just an amazing project, and the organization and the way you've deployed this to scale is just really, really impressive. So there's lots to learn.
And by the way, the next Immersive Learning Research Network conference is in Glasgow, Scotland. So how's that for exciting?
And online.
And online.
Don't say that
We'll
part.
go.
That's right. We'll show up in person.
We'll go, and you have to make sure our leadership knows we can only be there in person.
That's right.
Yes. Well, it's much better, far more impressive, collaborations and networking if you're there in person, of course.
We got to get those heads and headsets.
That's right.
It's no small thing to me that you guys are the second group to tell us that we should do something like an EXR for a broader community. So I think the time is, we've seen incredible shift even in the last year for people's receptivity to this. We just aren't seeing the same questions that we used to see. People are like, oh yeah, of course, but how do we do it? And so I think that could be something we could all work together on as well.
Yeah, that would be fantastic. Yeah, technology adoption is such a long studied but ever changing sort of thing, and I think it's going to require collaboration amongst lots of experts. And yeah, thank you so much for all your incredible pioneering work, and we'd love to collaborate with you. I think Awais Baig has raised their hand.
Hi everyone.
Hello.
Hello. So I think it was a really great session, and it was great to know how there are so many developments that are taking place around the world in the XR world. But my question is basically around the XR hype. First of all, I would like to connect it with the AI hype. I mean, there is a lot of work being done around the LLMs, and there is a lot of research work that is being done around in this field. But do you think that XR will also be is also a kind of hype, or is it also going to be accessible in every home, or are we going to use it in our workforce, in our education, like in schools, and is it going to be commonplace, in short?
My short answer is that I think the answer is both. And it has been our commitment. Caitlin and I are pretty allergic to the phrase shiny objects, I think, which might be surprising to people given the work that we've done over the last 7 years, but that has been central to the way that we've thought about how we've done this. Certainly with people coming at us with shiny objects, right? So I think it's both and I think our commitment to this is filtering through that, identifying where there's true meaningful potential, unique opportunities, and then really driving in that direction. Because I think as we do that, the value proposition quickly comes to light and people see, oh, we should have these things in every home or most homes, and this is why, not necessarily all these other things. So Caitlin, answer that.
No, I would agree with that. And do I think the technology will end up in every single person's home just in general? Maybe not. Like the use of immersive technology for gaming is still very real. You'll have it in households for that purpose. There may be some folks using it for, social interactions or even virtual meetings, which I don't find virtual meetings in VR to be particularly comfortable. But I think that when it comes to healthcare and increasing access to healthcare support and healthcare assessments and other things using immersive technology, I absolutely do think that could and already is becoming a thing. It is becoming true within healthcare that we can send devices home to patients. We can collect objective and subjective assessment data through that device and have it enter our healthcare systems for the clinicians to view in real time. You know, that exists. And so if we can provide that level of care from a distance, then I would be shocked if it doesn't become a normal thing within healthcare.
Okay. Okay. Thank you so much for your response.
Are there any other questions from the audience? No. I love and share that view. I think it's important as explorers to be skeptical and to be, you know, prepared to iterate or to pivot when the evidence just isn't there to support a particular thing. But I think, you know, I can't help but think that the next 5 to 10 years is going to be increasingly immersive and AI assisted in so many ways. And it may not necessarily be virtual reality. It may be immersive augmented reality, which I like to call when you're wearing headsets that have a wider field of view. But it's going to be increasingly experiential. Thank you so much for joining us again. We could probably have like a parts 1, 2, 3, 4, and 5 with Anne and Caitlin. And maybe we'll do that if you guys are free and interested in coming back another time. But I want to thank all of the participants for coming today. It was a great session, very informative for me, even though I've heard some of this before. And I want to thank President and CEO, Dr. Jonathan Richter, and my co-chair, Dr. Stephanie Justice, and thank you.
Thank you for having us. Yeah, and all the work you guys are doing too. I mean, it takes all of us. So thank you for what you're doing.
Yeah.
Happy to
It's
come
network.
back if you need us.
Fantastic. Yeah. Thank you so much.
All right, take care, everyone.